Good day. I'm Dr. Kevin Seaman. Working with Captain Heather Szymanski, we're working on giving you our 30,000-foot view of the new 2024 protocol update and some tips and tricks that are designed to help you. To get to this, you've obviously reviewed the 2024 protocol changes. We're not going to deal with every single one of those. Rather, we're going to go through 3 of them. Specific highlights for allergy anaphylaxis, go in depth on ventricular fibrillation, pulseless ventricular tachycardia, and then spend a short period of time on droperidol, which is a new antiemetic that's been added to the protocol. With regard to anaphylaxis, what has been done is to put the allergy protocol with the anaphylaxis protocol, and I think that's the right thing to do. What really we're dealing with here is a spectrum of disease that on the one end can be mild symptoms, a red, itchy skin rash that raises up, goes away, and comes up in another place, which we know as hives, but it can very quickly change, and in that change can become moderate or severe in symptoms. So if someone with hives says they have itching in their throat or feel some swelling in their mouth and throat or lips, that immediately boosts that up to a moderate level of allergy. The concern there is, are they going to swell their airway closed? And is it going to make a very difficult challenge for you all caring for this patient in the field? Given that, there are some other things that are important as well, and I want to let you know that anaphylaxis is undertreated and under-recognized throughout the healthcare spectrum, in the hospital, in the ED, also in EMS. At times it can be very difficult to diagnose. In fact, 20% of cases of anaphylaxis have no skin or mucous membrane signs, and that makes it more difficult. We're going to focus here on the best practices, which include early recognition, early epinephrine administration, appropriate IV fluid boluses, moving rapidly to an epinephrine drip if the IM epinephrine is not working, and then if they're moderate or severe, really what I call throwing the kitchen sink at them, giving them Benadryl as an H1 blocker, giving them steroids, giving them albuterol for any respiratory symptoms. So as mentioned, now you can look at allergy anaphylaxis as a spectrum from moderate to severe. To make a diagnosis, you need 2 or more symptoms from the category. And so of those, one is the skin and mucous membranes. Those would be hives in the skin or angioedema in the mouth, lips, throat area. Respiratory symptoms, including wheezing, hypoxia, or stridor, and hypotension are all signs. And if you have 2 of those signs, that defines anaphylaxis, moderate or severe anaphylaxis. In addition, you need to know something else, that if you have a patient with hives but nothing else, you need to ask them, have you had this before? Did you see a doctor? What did they say? What did they do? If they say, oh yeah, I had hives and then I had throat swelling and I was in the ICU intubated, that tells you that this hives for them can get very, very severe very quickly. And you need to treat that as a severe reaction, moderate to severe, going towards anaphylaxis rather than just simple hives. So that particular case, or for moderate or severe symptoms, we're treating all of those as if it's anaphylaxis. And I just want to make another point that this is what's called warm shock. There are only 2 types of warm shock, and this is one of them. I'll let you think for a minute about the other. But this is the hallmark of this, is that there's vasodilation, so a lot of blood flow goes to the skin, so it's warm to touch rather than being cold and clammy as we see with hemorrhagic shock. With regard to the other type of warm shock, you obviously know septic shock is warm because that is also a vasodilatory shock, distributive shock. Just to reiterate, 20% of these moderate or severe cases don't have skin or mucous membrane findings of hives or of angioedema. Anaphylactic shock is massive vasodilation due to histamine release, The heart tries to increase its output to deliver blood to the vital organs, but it can't overcome this vasodilation. The patient has both adrenaline, which is endogenous, it's in their body being secreted, and the epinephrine, and that's not enough to vasoconstrict either. So for this type of anaphylactic shock, what we need to do is give them the intramuscular epinephrine up to 3 doses. If that's not working, go to an epinephrine drip. And in this case, given those symptoms, we'd give them the kitchen sink, including the Benadryl as an H1 blocker, giving them the dexamethasone as a steroid, considering albuterol if there are any respiratory symptoms. So in terms of the protocol, let's say you've gotten to that point, you've given them 3 epinephrine IM, you've given them IV fluids, a 20 milliliter per kilogram bolus of lactated ringers or normal saline, probably lactated ringers. You've given them 50 milligrams of Benadryl, IV or IM. You've given them 10 of dexamethasone IV or IO, and you've given them albuterol for respiratory symptoms. The epinephrine drip is fairly simple to make up. You can do it at the bedside, and it can make a difference here if they're not responding to your treatments. You would take 1 milligram of epinephrine, which is 1 mil of 1 to 1,000 epinephrine, or it's 10 mils of 1 to 10,000 epinephrine, and put that into a 100 ml bag of normal saline. What you then do is mix it up, bleed the line all the way to the end, hook it into an IV that's rapidly flowing. And you would set it initially at 1 milliliter per minute and increase it up to 2 milliliters per minute, looking for an increase in their mental status, an improvement in their systolic blood pressure or their mean arterial pressure as a sign that this epinephrine is working. Obviously, giving them all the other treatments and getting them rapidly to the hospital is going to be life-saving for them, and a great job done by you. So to summarize on anaphylaxis, recognition is the history they give you, but then also that past history. If they've had severe, moderate, or severe reactions, it's going to change what you do. Hypotension with any one other sign is anaphylaxis, and you're going to treat this very aggressively, very assertively with IM epinephrine times 3. If that doesn't work, epinephrine infusion, the fluid bolus, 50 of Benadryl, IV or IM, 10 of dexamethasone IV or IO, and albuterol if indicated. I think by doing all these things, you'll have given them the best care. You'll stave their getting worse, getting till they get to the hospital, and you'll have done a great job, and we'll thank you for it. All right, moving on to our second topic, it's persistent ventricular fibrillation and pulseless ventricular tachycardia, of which you know a great foundation, and we're going to build on that here today. So this is a fairly wide-ranging change to the protocol, and this comes because of the DOSE trial, which is a trial done in Toronto, Canada by Dr. Cheskis. And this was a very well-done trial. It's a randomized controlled trial, which is very rare in EMS. He compared standard treatment in cardiac arrest for a witnessed arrest shockable rhythm to vector change defibrillation, which we'll talk about, to double sequential defibrillation, and looked at outcomes for all those patients. What he found was that both double sequential defibrillation and vector change defibrillation had increased survivors, increased neurologically intact survivors. He did not do a head-to-head comparison of vector change versus double sequential defibrillation, but compared each of them to the baseline, which was standard therapy. The other thing that we need to be aware of for this very well-done randomized controlled trial is they did something very good, which we ask you to do, which is defibrillate and get right back on the chest and start CPR again. When you do that, though, you don't get to see what the rhythm is for 2 more minutes when you pause the CPR to reassess do they need another defibrillation. So in Dr. Cheskis' trial, which was very well designed, the difficulty is we don't know if when they looked at 2 minutes and saw VF, did this recur? In other words, had it responded to the treatment and it recurred, or was it resistant and it never responded to the treatment? Those are two separate conditions for which separate treatments are needed, and we don't really know the answer to that. So based on that, it's going to influence what our choices are here in Charles County. So we're going to do a foundation that's the very basics that we do very well and we've done for a long time, which is the treatment of cardiac arrest. The foundation includes high-performance, team-based CPR, defibrillating as soon as possible, getting IV or IO access as soon as possible, giving epinephrine IV or IO as soon as possible. This includes managing the airway as least invasively as needed with bag valve mask or with a supraglottic airway. And there's a reminder here just to consider other causes that are reversible for cardiac arrest, like hyperkalemia. If you suspected that in a dialysis patient or for some other reason, you could give calcium. Sodium channel blocker overdose that we see with tricyclic antidepressant overdoses. You would treat that with saline and IV. And if you see polymorphic ventricular tachycardia or torsade de pointe, you would treat that with magnesium. So think about those things. If you see them, then treat them as reversible causes. This protocol would have you do all that foundation, do 2 defibrillations, and then after the second, consider them for transport to an eCPR center. And we're going to talk about that. In Charles County, unfortunately, we don't have a solution to get them to an eCPR center within 15 minutes. There are 3 of these centers in Maryland. 2 of them are in Baltimore, University of Maryland main campus, Johns Hopkins main campus, and then the Washington Hospital Center in Washington, D.C. So the closest for us by far is Washington Hospital Center, but we, from our geographic location, cannot get these patients to the Washington Hospital Center within 15 minutes, which is necessary for them to take 15 minutes to get them prepped and ready and start ECMO, essentially, extracorporeal membrane oxygenation, within 30 minutes of their cardiac arrest. So therefore, we're not going to transport patients to an eCPR center at this time. We'll follow this closely. This is a pilot protocol, and if it shows proof of concept, we may find that as time goes on with other iterations that there may be a smaller eCPR machine in the ED put in by ED physicians, and then the standard of care might be to do that in the ED and transport them to an intervention center after that. But right now, we will not be transporting to an eCPR center. The protocol has other parts, though, that we will be following. So this says after the 3rd shock, if you've not had success, so again here, this is shock, we give epinephrine, shock, we give amiodarone, give a 3rd shock and it isn't working, then we would do vector change defibrillation for the 4th shock by reorienting the pads. What you need to know about that is you need to coordinate that with Lucas placement so that you don't interrupt CPR for more than 10 seconds. So when you go to put the back plate on, you can roll the patient, put on the posterior pad, resume CPR, have the gantry on one side, resume CPR for another cycle. At the break on that, they can secure the other side of the gantry and start the Lucas device, but not to interrupt for more than 10 seconds. With defibrillation here, we're trying to change the environment for the defibrillation to work. It's critical that we get the pads in the right place. You'll see in the slide that I'm projecting now that for standard defibrillation, I'm going to ask you if that lateral pad is in the right place. Think about it for a minute, but I see that pad anterior. So we have an anterior pad and an anterior pad, which means we're going to send the electricity through the skin and soft tissues, but not through the heart. So that lateral pad needs to be the middle of it in the mid-axillary line to get that vector of that shock to go through the heart. Try to make sure you get that pad placed correctly when you first put it on for anterolateral placement. With regard to the anterior-posterior placement for vector change, you're going to put one pad on the left side over the heart and one pad directly behind that on the back to go directly through the heart for vector change defibrillation. So each of those, we're making a change, seeing if it's effective for this treatment. With those, if it's not, we would give the fifth shock in the vector pad change orientation, and we would administer esmolol. Esmolol is a beta blocker, and it's administered because in this setting, we think this could be what's called refractory VF, meaning the VF has not responded to any treatment so far, and that is usually thought to be due to what's called adrenergic storm. What that is the adrenaline in the body plus the epinephrine we've given stimulating the heart so much that it can't get out of VF. And then esmolol here would block some of those receptors and allow the shock to take over and be effective. So again, with the fifth shock in a different orientation with vector change and with esmolol, we're seeing if that works. At this point, you've given all the treatments that you are able to. We would package them and transport them to the closest appropriate cardiac intervention center rather than an ECPR center. I hope this has provided a 30,000-foot view and given you perspectives on how to do this best for the patients that you encounter with persistent VF, which could be either recurrent or resistant. All right, for our final topic, this is a little dessert after dinner. So this is pretty simple. This is droperidol, which is an antiemetic we're adding to the protocol, making it our second antiemetic in the Maryland Medical Protocol. The first, obviously, is ondansetron or Zofran. Droperidol, as you may tell, is a cousin of haloperidol, which we use for agitation with excited delirium because it has an antipsychotic effect. It calms people down. Droperidol has some of that effect in it, but it also is a very potent antiemetic. Its indications are for migraine headaches, for cannabis hyperemesis, and for cyclic vomiting. A couple pearls here. You can ask patients about their headaches and whether they have migraine headaches. Be aware that some patients call it a migraine headache because it's bad. So you need to say, as a doctor diagnosed a migraine, what have you been treated with? And I think some of the treatments for migraine are pretty understandable. You can ask them if they've gotten droperidol before and if it's helped. But droperidol can help migraine headaches. Now, there are two other indications for droperidol, and one of them I think needs some explanation, and that is cannabis. So when I talk to patients, I ask them if they use alcohol, and then more questions about their frequency of use and the amount they use. I talk to them about drugs and ask about drugs and have further questions on those. But I find very frequently that asking those two questions, I need to come back and ask a third question, which I would recommend in these patients, which is to say, do you use cannabis? To be surprised at times when they say, oh yeah, every day. These patients get high from cannabis, their stomach goes to sleep with cannabis, so it doesn't work. It fills up, but it doesn't empty, and they vomit over and over and over again, and this is called cannabis hyperemesis syndrome. The true treatment for this is stopping cannabis. We're not going to get them to do that in our time, but droperidol can help, and you can give them that, but you need to be aware what you're dealing with. I think you need to manage expectations to say this may help your nausea and vomiting. It is not necessarily going to make it get completely better. You need to be aware of that. In a similar way, there's a cyclic vomiting syndrome that may not have cannabis involved. Those also can respond to droperidol. So there are three indications: the migraine headaches, cannabis hyperemesis syndrome, for which you need a little bit more history, and the cyclic vomiting, and droperidol may help. If it helps there, that's great. If it's not, you could repeat, or you could give another antiemetic, such as the ondansetron, if the droperidol doesn't work. I could think in this way it should make it easier for you, less ambulance cleanups, make it better for the patient, and keep us rolling down the road. So a brief 30,000-foot view of the new protocols, some tips and tricks for those protocols. Be safe. You're our most valuable resource. We want you to take care of yourselves. Thank you for doing a great job. And on this day after Father's Day, I hope all of your fathers had a great Father's Day and you celebrated that relationship. Thank you. Have a great day.